Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
This activity includes discussion of off-license or unapproved therapies. Please consult your local SMPC or its equivalent for further information.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Ipsen.
This program is presented by Medscape Education Global.
Hello, I'm Darren Hargrave, clinical professor in Pediatric Neuro-Oncology at University College London, Great Ormond Street Institute of Child Health in the UK. Welcome to this program entitled Pediatric Low-Grade Glioma with BRAF Alterations, Stories, Science and Strategies. In the first chapter, we'll be looking at the burden of disease from a patient and caregiver perspective. I'm joined by Cameron Miller, Director of External Affairs and Strategy at the Brain Tumour Charity in Hampshire, UK. Welcome, Cameron. Let's start by watching a patient documentary. This is one of my patients who I've known since she was 15 months old, so known her now for over 13 years with her low-grade optic pathway glioma. When she first presented as an infant, she was failing to thrive, had visual symptoms, and a condition which does affect young children with this condition known as diencephalic syndrome. She was treated with standard intravenous hospital-based chemotherapy for 18 months. Unfortunately, over the years, she's required 5 types of conventional chemotherapy. She's also had surgery, and more recently, she's had 2 types of oral targeted therapy, both of which resulted in tumour stabilisation. But unfortunately, her vision, despite this, has continued to decline, and she's now severely sight impaired. She also requires hormone replacement therapies. Let's hear from her mum about the effects low-grade glioma have had.
I think the thing with the low-grade glioma is it's not benign. I mean, I wish people would stop using the word benign. It's horrendous. It wrecks your life, it just causes so much damage, and it's not benign. But also this whole idea of, it's low grade, so you don't have to worry about it. It's not true either, because the amount of damage this thing has done over the years. When my daughter's got very limited vision now, and that doesn't sound like low grade to me, But also how long this journey is, because just because it's low grade doesn't mean it ever sits down and shuts up and stops causing trouble. And she doesn't produce human growth hormone anymore and has to have injections every single night and all of these other things that come out of this supposedly low problematic thing. And I do think the medics tend to dismiss it a little bit. They think you should almost be grateful. And in the beginning you are, because you don't understand what you're in for, but yeah, feeling less grateful now, I guess, in many ways. Although, she's still with us and grateful for that. Having a kid who's got a tumor that you can't get rid of, it means that you are never, the fear is a huge one, because even when she's in a good patch, you know you've got a ticking clock. You know it's a matter of time before you're back on treatment. And also, theoretically, most kids, they apparently, I hear, that you have a couple of years of treatments and then you should have a couple of years grace, and then it's grown too much and you have to go back into treatment. And that's just never quite worked out for us that way, because of all the supposedly long gaps when we're supposed to not have to have treatment. Things have happened as a side effect. So she got a blood clotting disorder, which we were told would only last a few weeks, and ended up being with us for 4 years and was life-threatening. Now her school's terrified to let her take part in any sport, and now she's supposed to be on a break, but she's not on a break because everyone's treating her with cotton wool. And now she's progressively lost sight, and especially more recently she's quite catastrophically lost most of her sight. And, you know, in the beginning it was just terrifying, and we didn't know if it was going to go completely and leave her 100% blind, and we've stopped just short of that. Again, it's just been a case of how do we do things we used to do yesterday, last week, how do we do them differently today? And trying to give her constant hope around that there can be a plan, that there is a way of doing stuff, that her life doesn't have to stop. That's a really big thing, managing her fear and her anxiety. And yes, she is an anxious person as a result. She's really, really struggled, and she spends quite a lot of time not wanting to be alive because it's so hard. And I think the hardest thing of this whole journey has been managing her mental health and our mental health. The can do, you know, we can do this, just finding out how.
So somebody else who was just at the beginning of this, I might say, it's long. It's not always going to be easy. I don't want to say it's going to be easy because it's not. But if you have the right strategies, if you have the right things, and if you have friends and family you can rely on, that works. That really does help. And without that, I wouldn't be anywhere. I just wouldn't be able to be here.
So Cameron, that was quite powerful. What do you think about the challenges faced by our patient in the documentary we just saw?
I thought it was incredibly powerful, and I think that family is to be applauded for the bravery they've shown, not just in the challenges that they faced, but also in sharing their story today. The bits that sort of stood out to me, and I think will resonate a lot with the wider PLGG community, is the point about things being benign or being referred to as benign. You know, this is a condition that can have long-term, lifelong consequences. And actually what people feel is that when it's described as benign or somebody refers to it as benign, it almost undermines that lifelong impact that a diagnosis like this can have. And it totally changes the trajectory of the life that you thought you were going to live, or you thought that your child was going to live. And I think that's an exceptionally difficult thing to cope with. The other thing I thought that really resonated with me, and I think will resonate with a lot of people, is the ticking clock analogy that was used. I've heard other people in the community refer to it as a ticking time bomb because they feel like they just don't know what is going to happen next, and they just live in a permanent state of fear and anxiety. And that's exceptionally difficult to manage day to day because you just don't know when it's going to end, or when the next sort of phase of treatment or the next something is going to crop up that you're going to have to deal with.
Yeah, I mean, I think as a human being, uncertainty is one of the most difficult things in life. And you know, the thing with low-grade glioma is it is such a chronic disease. It really has different effects, different outcomes, different needs of treatment for each patient. So it's quite difficult to actually predict, which of course means that uncertainty, that ticking clock, you can totally understand. I mean, obviously, they both talked about some of the challenges they face. From your discussions with other patients with pediatric low-grade glioma, what are some of the things they tell you about they face, not only at the time of treatment, but actually after treatment and going into adulthood?
Yeah, I mean, it's interesting because obviously the physical challenges can include nausea, seizures, personality changes, things like that. But certainly in the conversations that we have at the charity, people don't necessarily want to talk about that. They want to talk about, as you're mentioning, the impact of those physical challenges on their life. And that can be trying to re-enter education and the difficulty, as is alluded to in the video, of getting teachers to understand what they're going through and treat them as normal children and not treat them with kid gloves, as was mentioned. That can be a real challenge. But also things like finding long-term employment. You know, where will they find long-term employment, and will an employer understand and be able to adapt the workplace for the needs that this person is facing in the long term? The other thing that people really want to talk about is is socializing, because actually lots of those consequences can have an impact on your social life. So if we're talking about social life, education and employment, I think you'd struggle to find somebody who say that those aren't three pretty big milestones in a person's life: navigating education, finding your first job or your first workplace, and socializing with people. Those are all pretty big developmental milestones, and PLGG has this huge impact on all three of those, which just means then that it just compounds those physical challenges into something much more profound. And that is really, really difficult.
Yeah, and of course, in this case, this has been all the way through childhood and now actually going into adolescence, becoming a young adult and trying to seek that independence that we all do, which is a challenging time for all of us. And then with those extra aspects. One of the things that was discussed in both ways was the mental health aspects, the impact of that, and perhaps do we pay enough attention to that, when we're thinking about the physical aspects, the hormone aspects, etc. What do you think with regards to that as a burden?
Yeah, absolutely. And I think the mental health impact is huge, not just on the patient, but on the wider family and the wider network around them. So, caregivers face a huge level of isolation and uncertainty. And at a time where they only want the best for the person they love, they are also dealing with new complex language and having to make decisions about things that are incredibly difficult. So it can be really isolating. And that's also without mentioning siblings. Siblings also are going through this at the same time, and they can have huge sense of guilt, around not being the child who has PLGG, but also they can also have some level of anger and resentment because suddenly they're not getting the attention that they used to, because their families are understandably supporting a child who needs it most. And those things all need to be, thought about, I think, and they need to be really addressed carefully. The one thing I would say certainly say to parents and the wider family and the wider network is always reach out for support, because have a genuine conversation if you're struggling, because that's so important. And unfortunately, there are lots of people who are part of this club that nobody wants to be a part of, but have been through it and may be able to give not only practical advice and support around some of this, but also emotional support, and just be a listening ear and understand what you are going through and be able to point you in the direction of more formal support should you need it.
So Cameron, obviously, peer-to-peer support, is vital. And you could see from the video that actually, patients can really understand what the journey may be like for somebody who's starting that. But it mustn't all fall on them and their families. And I think there is a role for healthcare systems. I was wondering if, how well you thought healthcare systems did manage patients with PLGG, particularly as perhaps they transition into adult care.
Yeah, I mean, we know that there are certainly challenges around that, and patients at times when they finish their paediatric care and move into adult care sometimes do describe being, left to fall off a cliff at times almost, because they have such strong care in the paediatric space and less so in the adult space. So getting that transition is incredibly important and will have an impact on, on their long-term care, and how they feel about the healthcare system around them. So I think it is vitally important that we get that right. Additionally, I would say in terms of PLGG, I think it goes back to what was mentioned in the video about low grade, because of this sort of slight ambiguity around whether it's benign, whether it's cancerous. Sometimes people feel like a level of uncertainty around what services they're able to access. And they may even get conflicting messages about what services they can access.
Yeah, I mean, I think we can all agree, and we got the message from the video that, this is, a chronic disease that doesn't finish when treatment finishes, and that support needs to be lifelong, not just for the patient, but the family around them. So, I think that we need to concentrate on that, even as we get better and more effective treatments.
Absolutely. Couldn't agree more.
So thanks so much, Cameron. I think that's been a great discussion and really helpful.
Thank you for having me.
So please continue on to the next chapter, where we'll be looking at diagnosis and standard management of pediatric low-grade glioma.
Hello, everyone. I'm Enrico Poker, pediatric oncologist from Padova University Hospital in Italy. I welcome you all to this second chapter entitled Pediatric Low-Grade Glioma from Diagnosis to Standard Management. In this chapter, I will go through an overview of pediatric low-grade glioma, including epidemiology, clinical characteristics, and main prognostic factor. And then we will discuss about standard management of pediatric low-grade glioma. So, pediatric low-grade glioma are the most common CNS tumor in children. Between 30 and 40% of children with a CNS tumor are indeed represented by low-grade glioma. The annual incidence is around 10 to 12 in a million of children below 15 years of age. Median age is between 6 and 8 years, and a proportion of them are associated with neurocutaneous genetic syndrome such as neurofibromatosis type 1. A small proportion of children present at diagnosis or during disease with disseminated tumors. In terms of histology, low-grade glioma represent a heterogeneous group of grade 1 or 2 WHO neoplasm with astrocytic on oligodendroglial features, or sometimes a mixed morphology. They are therefore distinguished from higher grade, more aggressive glioma based on these morphological features. In terms of anatomy, low-grade glioma can originate more often in the supratentorial area, such as the optic pathways or hemispheric region, but some of them also originate from the cerebellar or the brainstem and the spine. Low-grade glioma can present with symptoms and signs associated with anatomy and obstruction of the CSF flow. So localizing symptoms in the optic pathway, for example, or in the brainstem, generalized symptoms like the behavioral changes, endocrine symptoms, especially when the hypothalamus is involved, and signs of increased intracranial pressure. The natural history is of slow-growing tumors, which rarely are life-threatening. However, most of the symptomatic low-grade glioma, first or late, do need treatment. Negative prognostic factors for progression are inoperable tumor, infant age, disseminated disease, lack of neurofibromatosis type 1, and the presence of specific BRAF alteration. And this overall survival is very good, above 85%, but the progression-free survival is less than 50%. So an example of cerebellar juvenile pilocytic astrocytoma, which can be cured by surgery only. And on the other side, a hypothalamic chiasmatic low-grade glioma presenting in an infant, which will undergo multiple lines of treatment. Visual pathway tumors also can be associated with significant morbidity, specifically vision. Multidisciplinary care of children with low-grade glioma, so it includes surgery whenever is feasible, but in case of incompletely resected or inoperable tumors, an initial watch and wait strategy can be considered unless the patient is very young or present with severe symptoms, and there are various non-surgical options at progression. The most known treatment option historically was radiation therapy. Radiation therapy is the most effective treatment option for low-grade glioma in children, with excellent event-free survival. However, side effects on the long term are of concern, more importantly from the neurocognitive side and the endocrine aspects. Therefore, chemotherapy has been introduced since the 90s with a primary aim to defer need for radiation therapy in younger children. There are a number of chemotherapies which are effective in low-grade glioma, but all of them carry a progression-free survival at 5 years below 50%. Most of the chemotherapy carries short-term morbidity, but few of them also have long-term side effects. Prolonged treatment burden is significant with chemotherapy. And more importantly, children often need more than one line of treatment, and 20% will eventually need 3 or more lines of chemotherapy. Therefore, more durable treatment with effect is needed to mitigate disease and treatment-related chronic morbidity. And with this, I thank you for your attention. Please continue to the next chapter, which will discuss molecular testing and treatment in pediatric low-grade glioma. Thank you for your attention.
Hello, I'm Sébastien Perrault, Director of the Pediatric Neurology Program at CHUS-NGC in Montreal, Canada. Welcome to the third chapter titled Molecular Testing, a Cornerstone for Personalized Care. In the previous chapter, Dr. Opoker described the standard and historical approach to PLGG. However, we know that a significant percentage of patients fail therapy, experience progression, and require retreatment. This raises an important question. Why do some patients respond while others progress? If we look at these MRI from 3 different patients aged 4, 7, and 12, we can appreciate that the tumor location and appearance vary, suggesting that the tumors themselves are likely biologically different. Over the last 15 years, major advances have been made in the understanding of the pathophysiology and molecular drivers of PLGG. This insight have had important prognostics and therapeutic implications. Here's a case study of an adolescent with a long history of right-side hearing loss. Over a short period of time, she developed imbalance and consulted her pediatrician, who ordered an MRI. The exam revealed a heterogeneous enhancing lesion centered in the right cerebellar pontine angle. The appearance and evolution were suggestive of a PLGG. Following discussion with the neurosurgical team, the decision was made to proceed with an open biopsy rather than attempting a gross total resection, which would have resulted in a significant neurological deficits. The pathology was consistent with the pilocytic astrocytoma, a subtype of PLGG, and further molecular analysis revealed a BRAF V600E mutation. Let's better understand the significance of this alteration in terms of prognostic and treatment. Thanks to the work of many researchers and clinicians over the last decades, we now know that the majority of patients with PLGG harbor an alteration in the MAPK pathway. The most common alteration is a BRAF fusion, followed by a BRAF V600E mutation. A significant proportion of patients carry an NF1 mutation, with most of them having a clinical diagnosis of NF1. There's also an upstream alteration involving receptors, including FGFR. As you can see, most patients have a single driver alteration, quite different from what we typically observe in other tumor types, especially in adults. What is interesting and clinically relevant is that these alterations have specific phenotypical distribution. NF1 most often involve the optic apparatus, while BRAF fusion are typically found in the posterior fossa, and BRAF mutation, the cerebral hemisphere. Age distribution also varies. BRAF mutations are more often seen in older children, adolescents, and young adults. Clinical outcomes can also vary depending on the alteration. Retrospective studies have shown that BRAF mutations are typically associated with a worse prognostic in terms of progression and survival. These raise important questions about how we can adapt and optimize treatment strategies. Here's an overview of PLGGs. As you can see, the distribution of molecular alterations varies by subtypes. BRAF fusion are most common in pilocytic astrocytoma, while BRAF mutations are most often found in other subtypes such as pleomorphic ventroestosoma, or I call it PXA, and ganglioglioma. To achieve an integrated diagnosis approach to PLGG, several groups have issued recommendations based on available resources. These guidelines have evolved over time, particularly as access to testing such as next-generation sequencing has expanded. Once the histological appearance is confirmed by pathologists, the main goal in PLGG is to identify the single driver mutation in order to establish an integrated diagnosis. The first step is to look for an alteration in the MAPK pathway, such as classic BRAF fusion or mutation. If these are negative, less frequent alterations, such as FGFR, should be investigated. In certain cases, it's also important to rule out other molecular change suggestive of hybrid gliomas, such as H3K27M or H3G34 mutations, or in some cases, adult type low-grade glioma with HDH1 mutations. However, these alterations are only rarely found in association with MAPK pathway alterations. The approach can be sequential or giving improved access and reduce costs more comprehensive using upfront NGS panels optimized for PLGG. Regardless of the methods, it is essential to identify the molecular alteration upfront for all CNS tumors and especially for PLGG. Results should ideally be available within 2 to 3 weeks to guide timely discussion and treatment planning. In summary, we have a much better understanding of the molecular alterations that drive the development of PLGG. Early identification of these alterations is essential not only to confirm the diagnosis and define prognosis, but also, as we will see, to guide treatment. Thank you for your attention. Please continue to the next chapter, which we will discuss clinical trials data of therapies for PLGGs with BRAF alterations.
Hello, and welcome back to the fourth chapter in our program, entitled Evolving Treatment Strategies to Optimize Outcomes. And in this chapter, I'm joined by Sebastian Perrault. Welcome, Sebastian.
Hi.
Today, we'll be looking at clinical trial data from MAP kinase inhibitors for pediatric low-grade glioma, including data from single-agent MEK inhibitors, combinations of BRAF and MEK inhibition, and from trials investigating newer type 2 RAF inhibitors. As explained by Sebastian, most pediatric low-grade gliomas are driven by activation of the RAF-MAP kinase pathway. This has led to the possibility of using targeted therapies directed at different components of this pathway, such as BRAF, MEK, or even in the future, ERK. The first evidence leading to approval of such targeted therapy was for BRAF V600 mutated pediatric low-grade glioma, with the combination of the BRAF inhibitor dabrafenib and the MEK inhibitor trametinib. This combination has led to a more durable response and less side effects as a result of avoiding the so-called paradoxical MAP kinase activation, which can occur with single-agent BRAF inhibitors. This has also been seen in other BRAF V600 mutated cancers, such as melanoma. The pivotal trial demonstrating clinical benefit was the TADPOL-G trial, a company-sponsored study which investigated the combination of dabrafenib and trametinib randomized against standard of care cytotoxic chemotherapy, vincristine and carboplatin, in a 2-to-1 ratio in BRAF V600 mutated pediatric low-grade gliomas requiring systemic therapy. This was opened in children and young people from 1 to 18 years and used age-appropriate formulations. The primary endpoint was objective response rate as measured by RANO low-grade glioma criteria and via central independent review. The result of this study, which recruited 110 evaluable patients, showed a highly statistically significant benefit for dabrafenib and trametinib with an overall response rate, which included partial or complete, of 47% versus 11% for standard chemotherapy. In addition, when stable disease was added, this gave a clinical benefit rate of 86% for targeted therapy versus 46% for standard of care chemotherapy. This resulted in a median progression-free survival advantage of 20.1 months versus 7.4 months, benefiting dabrafenib and trametinib versus chemotherapy. And this met the pre-study criteria and was highly statistically significant. Turning to adverse events, in this randomized study, this showed that the combination targeted therapy resulted in half, 47%, grade 3 toxicities compared to 94% using standard of care chemotherapy. And as expected from early phase studies, there was a different pattern of adverse events seen. For targeted therapy, skin-related side effects were much more prominent, but usually lower grade compared to the typical cytotoxic chemotherapy side effects, which were from immune and bone marrow suppression, which often required blood products and management of infections leading to hospitalization. This was also reflected in a much better quality of life as measured in patients receiving dabrafenib and trametinib compared to chemotherapy. These results ultimately led to approval in many jurisdictions for this combination of at-home oral therapy for BRAF V600 low-grade gliomas. Sebastian will now illustrate this with a patient case before going on to discuss some trials with other low-grade glioma subtypes using single-agent MEK inhibitors.
Sebastian.
Thank you, Darren. If we go back to a case represented in Chapter 3, in summary, she had a large CP angle lesion that was biopsy and a BRAF D600 indication was identified. Based on that I've just presented, she was treated upfront with dabrafenib and trametinib. She improved rapidly, both clinically and radiologically, with a significant response visible within 6 months. She's a high-level hockey goaltender and now back with her team and have recently won a championships. This remarkable outcome would have not been possible with a more extensive surgery looking for gross total resection or with conventional chemotherapy. This case illustrates well the potency of targeted therapy for some of these PLGG. Given the impressive response observed with BRAF inhibitor, other clinical trials have started to investigate their use across all PLGGs. However, it was quickly shown that in patients with BRAF fusion, BRAF inhibitor can cause paradoxical activation, highlighting the need for a different therapeutic approach. To address this unmet need, the PBTC consortium launched a large clinical trial with selumetinib, a MEK inhibitor. The study includes several patient groups, including NF1, BRAF fusion, and mutation, who fail at least one line of treatment, most often chemotherapy. This study is still ongoing and long-term outcomes are under analysis. However, this treatment approach has already shown promising results, with tumor shrinkage observed in the majority of patients. Among those with BRAF fusion or BRAF mutation, 36% achieve a partial response, defined as more than 50% reduction in tumor size, 36% achieve a stable disease, and 28% experience progression. The 2 years progression-free survival was 70%, and now we have update that the 5 years progression-free survival is around 30%. Overall treatment was well tolerated, with mostly grade 1 and 2 adverse events and only few grade 3 events. The most common side effects with MEK inhibitors, such as selumetinib, are cutaneous and gastrointestinal, but these are usually managed without interruption of the treatment or reducing the dose. Another study looked at the MEK inhibitors trametinib. It was tested in patients with relapse or refractory NF1, BRAF fusion, or harboring other alterations. The study evaluated overall response rate, tolerance, and treatment efficacy. The analysis is still ongoing, but similar to selumetinib, most patients showed tumor shrinkage. When minor response was also included, defined as a decrease of 25% or more, the overall response rate over around 50%. In this study, patients were treated with a fixed duration of 18 months, but once treatment stopped, a significant number of them progressed. These highlight a key challenge with targeted therapy. Long-term treatment may be needed to maintain the tumor control.
Thanks, Sebastian. As previously discussed, paradoxical MAP kinase activation occurs with the use of first-generation BRAF-specific inhibitors. So these are not suitable for BRAF fusions, and as discussed by Sebastian, MEK inhibitors are being used for these. However, type 2 RAF inhibitors, such as tovorafenib, have been developed, and these are highly CNS penetrant and do not result in paradoxical MAP kinase activation, and hence may be effective in both mutated and fused low-grade gliomas. The Firefly-1 phase 2 study, a company-sponsored trial, was mainly directed at relapsed progressive or refractory pediatric low-grade gliomas with a RAF mutation. NF1 patients were excluded. They had to have measurable disease, and the primary endpoint was again objective response rate, this time using RANO criteria, again by independent radiological review. The study used both RANO high-grade glioma, which relies more on contrast enhancement, but is less relevant to pediatric low-grade glioma, and RANO low-grade glioma, the same criteria as used in the dabrafenib and trametinib study. But it also introduced a new pediatric-specific criteria called RAPNO low-grade glioma. All three demonstrated significant objective response rates in this single-arm non-randomized study, with RAPNO and RANO low-grade gliomas showing a 30 to 40% objective response rate, and when stable disease was added, this rose to 64%. And this occurred across BRAF mutated and fused pediatric low-grade gliomas. And interestingly, responses were seen in both those exposed to prior MAP kinase inhibitors as well as MAP kinase naive patients. The toxicity profile of this once-weekly oral therapy was not dissimilar to that seen with other MAP kinase inhibitors, such as dabrafenib, trametinib, and the other MEK inhibitors that Sebastian has told you about. This included skin rashes, nail bed inflammation called paronychia, but there were some differences seen with this specific drug. These included a high rate of hair depigmentation, and also it was noted that there was a growth velocity delay in patients who'd not completed puberty. This growth velocity delay is thought to arise from the fact that tovorafenib inhibits not only BRAF but also CRAF, and CRAF is found in the cartilaginous growth plates of growing children. Emerging data suggests that this occurs while you're on the drug, but in many patients, but not all, when they stop tovorafenib, this growth velocity decline will recover. So I'm going to hand over to Sebastian just to take us forward with the latest trials.
Yeah, thank you, Darren. So, given the promising radiological and clinical response with tovorafenib in relapse and refractory PLGG, a phase 3 trial was launched. It's a randomized upfront study comparing standard chemotherapy with tovorafenib. Enrollment is ongoing and results are expected within the upcoming years. So, based on recent clinical trials, treatment algorithms have been proposed by different groups. For patients with BRAF mutation who need therapy, the first-line approach is usually dabrafenib plus trametinib, with tovorafenib as a single-line option. For PLGG with other MAC pathway alteration, chemotherapy remains the standard for now, supported by long-term data on efficacy and safety. In case of progression with BRAF fusion, tovorafenib or MEK inhibitor should be considered. Currently, upfront treatment with dabrafenib and trametinib for BRAF V600 mutant PLGG has been approved by several regulatory agencies, including FDA and the EMA. More recently, based on published data, the FDA approved tovorafenib for patients with relapse or refractory PLGG harboring either the BRAF fusion or the V600 mutation.
So I think we can see that targeted therapies have been a major advance forwards for pediatric low-grade glioma, but there is much to learn and optimize about their future use. Sebastian.
Yeah, I think that the upcoming challenge will be the duration of treatment as well as the discontinuation.
I think it'll also be important that we're mindful to monitor for long-term side effects, particularly in young children, as obviously we have years of experience with cytotoxic chemotherapy, but the follow-up for some of these newer agents is relatively short. So that will also be something the community will need to look out for. So Sebastian, thank you for this great discussion. And thank you all for participating in this activity. Could I ask you please to continue on and to answer the questions that follow and complete the evaluation?
This program was presented by Medscape Education Global.